me. And I try to put things that I thought you might want to know, although I'm not really sure what you want to know. So if you have questions, please ask me. I don't know, put them in the chat. I'll try to keep an eye out or just interrupt me. I can go through, I mean, I have a lot of slides. I don't have to go through all of them, but I just kind of wanted to cover some of the um, things that I consider important, at least here at Memorial. I realize that not everything translates at, at across the street. I don't have any relevant disclosures. So I would just start off with CTs. And, we usually think about MRs and we do tons of MRs, but, CT still has a role. It's really useful because it's really easy to get. And that's like the biggest thing, right? Especially now, if you don't want to wait 2 weeks or 3 weeks or more for your patient to get MRI, you can get a CT and you can get an answer right away. And really, CTs can get added on with no problem. It's a little bit trickier now because the global CT contrast shortage, which is mostly GE because of Shanghai. But still CT has a lot of use, especially for kind of urgent kind of findings or new symptoms or new kind of things on exam. And that's not to say that CT is really straightforward. It can be tricky to read as well. So these are two patients, and they're both 50, 70. They're not kids, and they both are done without contrast. And you can see how you can get multiple planes. You can get pretty nice images of the brain. You do get some streak artifacts. So CT is X-ray based. So as this X-ray beam goes through the skull, you get this beam hardening, and so the X-ray gets attenuated, and then it gets miscalculated through the brain. You can see how these streaks are partly because of the bone, and especially prominent near the base of skull. So with that being said, this top image, it's a little bit too tight. You should see a little bit more CSF. You should see a little bit more CSF around the brainstem, around the cerebellum, along these hemispheres. You can see CSF in the ventricles, third ventricle, fourth ventricle here. You can see the CSF in the occipital horns. You can see the sulci here. You don't really catch that on the top row. And if this top row was a 20-year-old, then I would say that's probably okay. But for a 50-year-old with chronic illness, probably too much. And this was pretty extensive lepto. And if you look back, you can see all this linear leptomeningeal enhancing stuff along the cerebellofolia, pretty extensive. You can just see that the cerebellum is a little bit too dense, but it's pretty subtle. It's not super straightforward. But even CT has a use. I mean, I think most of us hopefully would call this CT abnormal. I don't expect you guys to necessarily call it abnormal, but if it doesn't match, patient symptoms, then you start with a CT, kind of rule out something really, really big and bad happening, and then you kind of move on to MRI anyway and get contrast anyway. So lepto in melanoma is pretty uncommon, about 1%, but it does happen, and you can have lepto in the brain as well as in the spine or along the spinal cord. Another thing that CT is particularly good for is looking for blood. And the reason is that acute blood or bright new blood is usually dense on CT. And so before in the lepto, you could see that there was a little bit extra density or a little extra brightness in the posterior fossa because of the cells. And here the brightness is really due to blood. And you can see a little bit of brightness in the sylvian fissure on the right. You could see maybe there's a little bit extra low density on the CT in the occipital lobes. And then we go to the MR, you can see the low density edema corresponds to these flare abnormalities. PRES or posterior reversible encephalopathy syndrome, classically fried occipital lobes, maybe bilateral, usually bilateral, maybe asymmetric. And a small portion of them do have hemorrhage, and a small portion of them also may have diffusion abnormalities. This one does not, which is usually worse. They can progress to infarcts. So it's basically a vascular event. And so but you can see how this CT shows this subarachnoid hemorrhage pretty clearly, and it's just not visible on the MR. And so on the MR, that area looks completely normal. And even on the SWI, which is supposed to be our blood sensitive sequence, that area looks completely normal. And the reason is that acute blood is hyperdense on CT, usually stands out right away, but acute blood is actually almost isointense to CSF on MRI. So MRI has this kind of, you can stage blood products, and we can usually characterize blood pretty accurately, but the very, very acute blood, MR does a terrible job with. And so if you are concerned, your patient fell or hit their head, and a CT is still the way to go. And I don't think anybody could ever say don't get a CT. So this is one of the reasons why, because acute blood just shows up really nicely on CT. So if you follow blood and you have, just non-tumoral kind of hypertensive hemorrhage, classic, basal ganglia, fairly large, it will go through these stages where over a period of days or weeks, it will get less and less dense, and it'll get smaller, hopefully. And so, this is a patient with, bland hemorrhage, and, it gets less dense. So, and it gets smaller, which is classically what you expect blood in the brain to do. So once you have a tumor, though, this time frame goes out the window, because the tumors can ooze and continuously, bleed. And so tumors don't have a particularly characteristic time frame. We might be able to guess, if it's really new or a little bit older or very old, but it gets very tricky. And there's, this whole table of things that you can think of to try to say whether or not blood is new or not on MR. The easy way to think about it is that the very acute blood, the brand new blood within hours, even within a day probably, you're really going to be hard to see on MR, because it's going to be close to CSF. So it's going to be nearly, identical to CSF, very hard to pick out. By the time it gets to bright on the T1 pre-contrast, which this is, and you can see this one is the post-contrast T1, you can see some enhancement of vessels. By the time it gets to bright on the pre-contrast T1, it's subacute blood. And so that's, somewhere around a couple weeks old. It's either subacute intracellular methemoglobin or extracellular methemoglobin, it doesn't matter. It's at least a couple weeks old. And that's the kind of blood that we typically see on MR, because they don't commonly come in right away after some event to get an MRI. And by the time you see the hemosiderin rim, or this dark rim on the SWI or on the gradient images, that's older blood, so more than a couple weeks old, usually a couple of months old. But again, if you have a cancer, or if you have a tumor and you bled into your cavity or into your tumor, some tumors like melanoma, thyroid, renal are very classically hemorrhagic or commonly bleed. You may get this picture persist for months, and I've seen it for years. So just because the staging of blood was worked out for hypertensive hemorrhages in patients without cancers, it doesn't work in patients with brain tumors. And this is an example of just hemorrhagic met. It's, again, mostly bright on the T1 pre-contrast. So the outer rim is methemoglobin or subacute blood. The middle is darker on T1, so the newer part is actually newer blood. So you have some more acute central blood, you have some more peripheral subacute blood, and then you have a part of a rim of dark hemosiderin. So it's kind of all different stages of blood. And you can see how over a couple of months, this one did decrease, but you can still see that there's still some areas of bright blood, some areas of dark blood. It's kind of a mishmash of things going on. So there is more overall, more chronic blood products and fewer acute or subacute blood products, but still very, very mixed. And it's hard to date based on just that without any comparison. This is just one more kind of warning of MRI and CT. And this is a young man that came in, and he has leukemia, and he has this obvious abnormality. It's bihemispheric. So we had some internal debate about what this represented. And in occasion, we're a cancer hospital, right? So most of the patients are going to have some kind of tumor. but it doesn't always have to be tumor. And the subdural hematomas will stop at the sutures because that's where the attachments are, but the epidural hematomas will cross sutures. And so this is, actually a fairly sizable subepidural hematoma in this kid who just had spontaneous bleeding because of his underlying leukemia. And so, you can actually see on the MR, it's not quite CSF, it's a little bit brighter than CSF, but on contrast, you can actually see, these bright areas of contrast. It's not enhancement, it's actually extravasation of blood into this epidural hematoma. And so, this patient went to the OR the same day and they evacuated. And, for small epidural hematomas, they might observe now, but, for, fairly largeable, sizable epidural hematomas or any hematoma, he has some mass effect. You can see the brainstem pushed a little bit here. And, we have active bleeding on the MRI. This is, a case that needs to go to the OR. And so the last piece about blood, I think, is that the blood can look diffusion restricted. So usually we think of the things we think of when we see brightness on the diffusion image are usually kind of stroke and hypercellular tumors. But blood is a great mimicker, and blood can look diffusion restricted, and it's just blood. It's not tumor. It's not a stroke. It's not an abscess. Just blood, depending on what stage it is, can have a very varied appearance, and that's the trick, right? So on MR, depending on how old the blood is and what kind of lesion it's in, if it's in a tumor or not, can be really variable and pretty tricky. Whereas on CT, you just have to, worry about, is it bright and is it getting less bright? And so that's a huge kind of very straightforward algorithm. The other, thing that keep in mind for, if you're ordering a CT or an MRI is that MR is really good for brain lesions, for soft tissue discrimination. CT is good for blood, kind of acute things, and CT is also really good for bone. And the reason is that bone on most sequences on MRI looks dark. And so you can see how, dark skull, and then there's a little area or smaller area posteriorly that has kind of this intermediate gray that is kind of darkish, but not quite as dark as the rest of the skull on the T1. And it enhances on the contrast, and there's probably some dural spread. And so, in a woman, you might be concerned about, a metastasis from breast or kidney or lung. But, she gives this funny history of, since age 13. So, no respecting tumor would hang around for 4 decades, right? So you do CT, and the CT is classic for fibrous dysplasia, right? So it has this very characteristic ground glass appearance. It can grow, it can have malignant transformation into something worse, to a sarcoma. It can have lytic phases, it can have sclerotic phases, but once you see this kind of very typical ground glass sclerotic density, then you could be pretty reassured that unless you see a large soft tissue component at this point, that it's just fibrous dysplasia, it's a benign fibroosseous lesion. And it doesn't matter that the MR looks scary, that the MR has a lot of enhancement. So, for skull things and bone things, the CT still, has a lot of advantages over MRI. And this is 4 years later, and it did grow. It could get a little bit more, extensive out more laterally, but still looks like fibrous dysplasia. There's still no soft tissue component, and it's still probably just kind of remodeling bone. Okay, and so with CT, even though CT is like really easy to get, and for the time being, there is, I don't know how Cornell is handling it, but at least at Memorial, we kind of have some constraints on who can give contrast to. But even if you have a patient who can't get MRI, I think CT with contrast is something that is valuable. And we probably don't do enough of that here. If they're getting a screening CT chest, abdomen, pelvis, and you're screening for brain mets and you have zero suspicion, then it's perfectly acceptable to get a CT contrast rather than send them to an MR as well. And, you know, I mean, in the short term, like that's a little difficult because of the contrast shortage, but CT with contrast can be super useful too. And this is from when I was a resident at Bellevue, and this patient got shot decades ago. And so they're hanging out on the floor, unrelated to, you know, kind of everything else that's going on at that time. But he was obtunded and he was like, you know, in bed and they couldn't rouse him. So, you know, yes, he has a gunshot wound. Yes, he has a pellet and some kind of, you know, I wouldn't want to put him in an MRI. You don't really know what's in a bullet, how much lead there is, and how much, you know, other contaminants there are. So you don't want it to move around. Although, you know, if it was remote, then it's probably scarred in place. But nobody I know would put him in an MR, right? So you're kind of stuck with CT. And if you ignore this area with the bullet fragment and the gliosis next to it, you just look at the rest of the brain, again, it looks too tight, right? So you don't have a lot of CSF. You should be seeing brainstem. You should see CSF around the brainstem. You should see CSF, you know, in the cell side. And, you know, yes, he's young, but, you know, it's still a little bit too full, too much, too tight. And if you go up higher, you can see there's all these low density areas and you have some nodularity. This is all without contrast on the top. And when you give contrast, you can see all these enhancing nodules. And, you know, some of them are in the sylvian fissures or leptomeningeal. Some of them are going along the subpenile margins of the lateral ventricles, along the fornices. And, you know, really, really quite extensive. You know, it wasn't until then that they decided to image his chest, and he has these lung infiltrates, and it turns out he has neurosarcoid, right? So, you know, you went from gunshot wound remote to being untunded to kind of like finding out what was going on with him. And, you know, he got treated, and actually, you know, a couple weeks later, he's like walking around supposedly. These two images from the bottom were from MRs from a different patient. This is Bellevue, right? So we didn't do an MR in him. We wouldn't have done an MR in him anyway, but MRs were more difficult to get then. But neurosarcoid has a very variable appearance, and it could be, you know, lepto, it could be parenchymal masses, and you could have even just perivascular spread or just spread along the spaces of where the penetrating vessels are going. And so, you know, this patient has some lepto, but this patient has a more subpenile kind of perivascular spread. So, you know, even if you can't get an MRI, a CT with contrast has a lot of value. CT with contrast right now is probably a little bit difficult. This is Andy, and I just make a joke because I didn't make this webpage, but people that make these web pages love radiologists pointing at things, although we never point. And but then if you go to another page, that's me pointing, and I did that like 10 years ago. So, you know, I never point, but I did in that picture. Okay, so I'm going to switch gears a little bit and talk a little bit more about MR, and then I'm going to talk a little more about like how we work up tumors a little bit. And hopefully, if you have any questions, please ask or interrupt me. So again, you know, MR is, you know, is not good for acute blood. It's not great for bone lesions, as kind of just talked about. It is really good for old blood. So old kind of chronic blood, things that have been bleeding for a long time, like aneurysms, AVMs, tumors that have been kind of oozing and bleeding. And so this is, you know, the CT without contrast, and there's a, you know, mass in the right choroid plexus. You can see how asymmetric it is. But really there's nothing else much going on. And the MR, the regular, you know, this is a flare in T2 and T1 and T1 post, and you can see the mass in the right lateral ventricle, but not much else going on. And it's not until you look at the SWI. So SWI is a gradient weighted sequence, and all that means is that when we do the MR, we don't have a refocusing pulse. So the spins that are caused by blood don't get refocused, and so they kind of, you know, get magnified. And so even small amounts of blood, old blood, can show up. And so you can see how there's just a ton of low signal intensity on that SWI in the tumor in the lateral ventricle, but also in the sulci, in the sylvian fissures. And so this is, you know, a hemosiderosis, or just kind of like chronic blood products over the surface of the entire brain, and also in the ventricles and in the right occipital horn, because of this probably from this mass that was bleeding. You can see, If you look back at the CT now, there's still nothing out along the hemisphere, but you can see there's a fluid hemorrhage level on the left occipital horn. We don't catch that on the MR, but we have blood in the right occipital horn. So blood can also redistribute. And so, and again, depending on the stage, we might not capture it on the SWI or the gradient sequence, but it does a really nice job for old blood products. And the other thing for MR, and this is an advantage you guys have over us, is that you see the patient and you have a lot of clinical relevance. And I don't know how many of you remember Jerry Posner, but he was kind of this wonderful neurologist, and he wasn't. I wasn't. I'm Neuro-Radiology, so I'm in a totally different department. But I have a lot of respect and admiration for Jerry, because he kind of just kind of keep on a problem until it makes sense. And this is a patient not that old, not super young, but not that old, and came in and tremors and kind of some language problems, right? So we see this 4-centimeter meningioma, and we're like, okay, great, 4-centimeter meningioma, patient's booked for the OR, and the surgeon's ready to bring him to the OR later that afternoon. And Jerry comes up and Jerry's like, this doesn't make sense, right? And that's the advantage of being, actually going to see the patient and examining the patient, talking to the patient. And it's like, yes, this is a 4-centimeter meningioma, but it's fairly large. How do I know it's a meningioma, right? It's extra-axial. It's actually, you can see brain kind of getting pushed rather than being in the brain. The brain is getting pushed out, inward, away from it. It's fairly well circumscribed. It has some bony thickening here, and that's very characteristic for hyperostosis for meningioma. So it has this kind of bone reaction, has an enhancing dural tail, has a CSF cleft, and it has, it's slam dunk meningioma, right? But there's not a lot of edema. And language Broca's area would be around here, so nearby. Wernicke's area is probably a little bit further posterior to the lesion. So not clear why this would cause language problems, because it's in the area, but there's not a lot of edema, or really no edema, I'm showing you here. And Jerry's like, there's something wrong. This can't explain her symptoms. And then we looked at the scan again. She has this, the meningioma is diffusion restricted. So diffusion restriction, again, classically think of strokes or infarcts or hypercellular tumors, but almost any tumor can be diffusion restricted or not diffusion restricted. It's not consistent, right? So brain mets, primary gliomas, they may or may not be diffusion restricted, and it doesn't really mean anything. It doesn't mean that they're more likely to progress or less likely to progress or more likely to die early. It just sometimes it happens. And we've also said that diffusion restriction can also be mimicked by blood, where the blood kind of has a variety of variable appearances. But if you look again at the rest of the brain, there's also some diffusion restriction in the caudate nucleus, maybe a little bit in the putamen, in the basal ganglia on the right greater than left. And patient actually ended up having CJD, right? So Creutzfeldt-Jakob, it's one of those prion diseases. Most of them are sporadic. But this is the last patient you want to bring to the OR, right? Because if you bring them to the OR, you have to basically throw out all your instruments and everything the patient ever touched, because you can't autoclave the prion out. And so, it would have been, resecting meningioma would have not have helped the patient, and you would have, brought the OR down to its knees for, a good few days. And you wouldn't help the patient, right? So the patient actually, died a few weeks later, quite rapidly. But this is something that with the clinical history and the clinical scenario that radiologist doesn't necessarily know, you can really help to make that kind of diagnosis. This is another example of just very bright basal ganglia, caudate nucleus and putamen. This one also has this hockey puck sign of bright thalamus, medial and dorsal thalamus. You can have some bright areas in the cortex. And so, again, I don't really expect you guys to look at enough MRIs to kind of make this diagnosis confidently, but it's a great help if you tell us, if you take what we tell you and say, Does that make sense? Does that explain the patient's symptoms or how they're doing? And if you do look at the scans, and I encourage you to look at the scans you order and scans on your patients. I think the money shot is really, is there symmetry? Yes, no, and is there something bright under diffusion? And again, there is a differential, but if really there should not be any normal stuff that's bright on diffusion. So if you look at this one sequence, even on this one sequence, you can see, is there any bright? And if there's nothing bright, if you scroll through that diffusion sequence, if there's something big with a mass or massive factor or compression or hydrocephalus, you'll see it on that one sequence. And so that's kind of like the really super quick way to screen an MR if you don't want to wait through, thousands of images. Just go through that one set, and if it looks good on that, then doesn't mean that it's completely normal, but at least there's nothing major going on. So we do a lot of advanced MRI, and these are all sequences and things that we've done over the years that I've been here. Not everything is available right now. A lot of it is funding dependent, and kind of where we are in terms of research projects. But we do a lot of perfusion, and Cornell also does a lot of perfusion, and so we also do a lot of just straightforward FDG PET to evaluate our patients with brain tumors, and I'll go into a couple of reasons why. So when I started training, which is going further and further away, we would get actual film printed, right? And we would have to take the film, and we would have to take a piece of paper and hold it up and use a pen and mark off, the tumor goes from here to here, and then we would try to take that, and then we would line it up to this ruler marker and say, how many clicks or how many dashes it goes through, and that's how we would measure, right? So it's kind of like really old school way of measuring, and again, we're pointing, but we really didn't get much better in terms of how we measure in terms of of just kind of measuring. So now we have digital calipers, we measure on packs. It's a lot more accurate, but we're still measuring. And so the bottom line is that a lot of the things that we measure, the reason why we measure them is because all the response criteria say use measurements, right? And the RANO brain metastasis or RANO BM and the RECIST 1.1 are the two most common things that we use for brain metastases. They use one dimension, so you just measure the longest axis of any tumor, and you're kind of done. The RANO or modified RANO for primary gliomas uses two diameters, but again, you're measuring the diameters of the tumor. And so, this is kind of joke of you can measure things, and then you have specific sizes depending on when you calculate it and when you decide to trigger progression or not progression or response, but it's still all measurement based. And so what enables all that is to the standardized brain tumor imaging protocol, which Ben came up with, and most of the clinical trials have adopted. So these are just kind of some standard kind of minimum technical parameters for us to follow when we acquire the images. And the reason why we go through and we add perfusion to most of our brain sequences is that we find perfusion to be really useful. And so the size criteria are, again, based on just one dimension or two dimensions. But we know that some things that grow are not necessarily tumor, and to sort out those growing lesions, but whether or not they're actually tumor, we rely on perfusion. And I don't know how Cornell's brain protocols are anymore, but I know they have a couple of the same or very similar ones to us. We do have a menu of different protocols, and I would say the brain HEG METs is for most primary brain tumors and metastases that have active tumors or getting treated, or on clinical trial. This kind of satisfies most of them. The LGG goes through and adds a 3D flare, which we find to be useful for the non-enhancing low-grade gliomas. And then we have some, very short protocols for ruling out hydrocephalus or ruling out stroke, or just for SRS planning. But even still, we have perfusion across many of these protocols. And really, the the rationale is because, size is, we use size all the time, and but we know that size is imperfect. And so things that are responding may not necessarily decrease because you have more cytostatic effects rather than cytotoxic effects. And things that are growing may not necessarily be progression because you can have pseudoprogression or inflammatory immune modulated kind of changes. And so I'm gonna skip this. And really, this is something we kind of went through and with Andy Lin here. And if you look at brain tumors and you measure just one dimension as what RECIST 1.1 and renal brain metastasis as, or two dimensions as renal for glioma says, or you actually measure a 3D volume, which is a lot more labor intensive, you can see that they're all really well correlated. And so that's the key, right? So we do those response criteria suggest, they require one measurement or two measurements because it's really correlated very well with three dimensions, not because they're better, but because they're just really highly correlated. And you can get very similar information with less effort. And if you're looking for a large percent increase to trigger progression or trigger partial response, then that slight overestimation or underestimation is not as important. But we've seen plenty of examples where you have a mass or a tumor, and if you measure just one dimension or measure just two dimensions, you may actually miss progression as the tumor starts to grow and in another dimension that you're not capturing as well. And so what we've been doing for our low-grade gliomas is longitudinal segmentation. So this is completely manual. We're developing some in-house kind of automated tools, and we're shopping around, still talking to different vendors. But for right now, it's completely manual. And so it's usually somebody that sits down and draws like a kid. You draw an outline around the entire tumor, right? So sometimes for this, it is not well defined, but it can be fairly straightforward. If you go back to this one, it's really not straightforward, right? So you have this slightly expansile lesion along the posterior lateral margin of the surgical cavity, but you have all this other flare malady that you have to decide, do you measure that or not measure that? And if you measure that to include everything, then you may lose this percent increase because of the the actual tumor part that's growing. You're including a lot of gliosis. If you don't include that, then you have to be, hope that you're right, that you're measuring the right thing and actually tumor and not something else. Sometimes, something like this, it's going around the surgical cavity, and it's not necessarily a smooth line, which is completely fine, right? So our sequences are kind of standardized and they should be the same, but you can see that they're not. And this is a patient, and these scans are a little bit older, but you can see how these flare images are just angled differently, right? So that they're angled a little bit differently. The lesion is storing a little bit more anteriorly, it's storing a little bit more posteriorly, and that plus slice thickness and coffee affects the smoothness of this line. But if you look at it over multiple time points, it's clear that this group tumor is growing, right? And it's clear that there's an upward trend. And then then you can have a discussion between the clinician and the patient. Is it time to start drug or start radiation or consider surgery again? This patient actually grew. They got temozolomide. It flattened them out really nicely for a short amount of time, and then it started growing again. And again, just to go back, these low-grade gliomas in particular, because they're non-enhancing, they have pretty ill-defined margins. They can be difficult to segment, and that kind of explains part of the reason why there's some bumpiness in those longitudinal volumes. And you can see how when they're pre-op, it's pretty straightforward. Especially if they get radiated and you see like white matter abnormalities, it gets to be fairly tricky to decide where the margins really are. We also can co-register images. This is done in Alea, but we have a couple of options for co-registration. Again, just to show that tumors can grow, and these low-grade gliomas, because they grow so slowly, that growth can be difficult to capture. And so volumes is it's a real program that we put together here to kind of evaluate the low-grade gliomas that are commonly on just being observed. Again, it has a another resection and then just starting to grow. And the axial images, these are co-registered, and you can see the third ventricle and the foramen of Monroe. This is pretty precisely co-registered. It's almost identical axial images. Very similar technique. This one's a little bit more noisy than the other two, but growth on the axial images is much more difficult to pick out than just look at a line. It's shallow, but it's clearly upsloping. And sometimes that can push us to decide, it's growing, it's clearly growing, that the patient should go on treatment, in this case with an IDH inhibitor. And again, you can see that this nodular area is the tumor. This other flared malady is just post-op. And so this nodular area is growing. You can see how it's expansile, has kind of convex outward margins, and that convexity or that roundness flattens out and flattens out more as the tumor responds. So that's for low-grade gliomas. So back to size. So it used to be pretty straightforward. You resect a mass, and if you resect all of it, you can call it complete resection. If you resect part of it, you call it a subtotal resection. And when it grows, if it goes completely away, you can call it a complete response. And then when it grows again, you call it progression. And it wasn't really too much thought required. Except that we've seen patients like this where they grow. This was pre-op, this was post-op, there's just minimal residual. And then right after completing radiation temozolomide, you have this 6-centimeter mass, right? And this is really scary, except that the patient was not symptomatic, right? So because the patient was not symptomatic, because we had a high suspicion for pseudoprogression or some kind of radiation injury, we just put the patient, just watch the patient. They actually didn't even give him temozolomide. Usually they go on adjuvant temozolomide, but he refused because he said, well, the temozolomide didn't work, right? Because you just gave me a radiation and temozolomide. And so this is, the next, year with no treatment at all. And, the size doesn't really change all that much, but the amount of the enhancing soft tissue decreases, and the amount of the non-enhancing cystic necrotic change increases. And so from 3 to 8 to 11 months, this is clearly pseudoprogression, right? It's hard to make that diagnosis based on this one scan. But if it's asymptomatic and you can follow him, he actually does really well. But, at some point he actually grew back, and we can't cure these yet. So progression at some point is inevitable. But there is this known phenomenon for pseudoprogression. So just having a growing lesion or a new enhancing lesion by itself in patients, especially with primary brain tumors, but even with brain metastases, we have to do something else to try to confirm that it is progression in a lot of cases, especially if that got treated. And the pseudoprogression in gliomas is associated with MGMT, which is a DNA repair enzyme, and having a methylated or inactivated MGMT can potentiate the pseudoprogression because you're not fixing the DNA damage you're inducing by the treatment, which is the alkylating agent plus radiation therapy. And so patients with methylated MGMT have higher incidences of pseudoprogression and are thought to be more responsive to temozolomide and thought to have better survival, not because of the pseudoprogression, because they are more responsive to temozolomide. So there's all kinds of other interesting correlations you can make, but just based on the imaging, just a new enhancing mass or large enhancing mass does not necessarily represent progression. These are two different patients, and you have the flare and the post-contrast T1 in one patient, and then the flare and the post-contrast in another patient. They both had complete resections. They both got radiation plus temozolomide, and they were both on adjuvant temozolomide. And this is where perfusion can be really helpful, right? So the patient on the left has high K-trans, which is a cell membrane kind of blood-brain barrier leakiness measure. So it's kind of how leaky your blood vessels or your tumor is. And plasma volume is analogous to blood volume or relative cerebral blood volume or just perfusion. And so this is correlate with microvascular density at pathology as well as at catheter angiography. And so having high perfusion, high K-trans is consistent with tumor. And this left patient had tumor, You can see the right patient is kind of mixed, very heterogeneous, but not quite as high. And there are some small areas that are high, but most of it is fairly low. And this is sickle regression, and this has real implications for survival. You can imagine if you progress, if your tumor grows really soon after completing radiation, then you're probably not going to do so great. And so the patient kind of had relatively short survival. This one had, almost triple survival, and they both got resected and kind of had histopathology. So for those protocols that I showed you earlier, we include a lot of T1 perfusion, and this is kind of busy and it gets a little bit busier, but the basic point is that if the T1 perfusion is hot, then that's a pretty good sign that it's progression. If the T1 perfusion is cold and they're not on Bev, then it's also a pretty good sign that it's not tumor and some kind of treatment effect. And you can just kind of continue to follow them. What we get into trouble is if we had this big basket of warm or mixed and kind of heterogeneous perfusion, in which case you have a couple options, at least at Memorial. So this is not a really idealized workflow. It's just exactly what we do here on a routine basis. So you get perfusion, and then if it's hot, we call it tumor, and you kind of change treatment, go surgery, go to radiation. If it's cold and you're not on Bev, then we just kind of follow you a little bit more. If it's warm, what we'll do is we'll either follow you anyway, we'll add spectroscopy, we'll add delayed contrast, or we'll add FDG PET. And the reason why we add these three things is that they have different roles, and they all of them kind of offer slightly different information. And so, the real beauty is that you want, multiple pieces of information, and they're all somewhat independent of each other. They're not dependent on each other. So if you could get multiple pieces of information that all agree, then you're in pretty good shape, or at least you feel pretty confident in whatever you decide to do. You don't necessarily have to be right, but at least you can feel better about it. So this is a patient, a glioblastoma, and if you go across the top row, presentation, complete resection, some blood in the cavity collapses, there's a little bit of enhancement, nothing really going on. This is lower in that same patient at 7 months. So lower down below the surgical cavity, there's something going on, but then he develops something in the frontal lobe. And so this has to be tumor, right? There's no doubt, because it's nowhere near the surgical cavity. It probably got a little bit of radiation, but not a lot of radiation. And so it's not within the radiation field. 80% of the glioblastomas will recur within 2 centimeters of the primary site. And this is far enough away that you can feel pretty sure that it didn't get high dose radiation. It got exposed to some chemo probably, but this is growing. It's clearly tumor. So there's no doubt that it's clearly tumor, right? If you do perfusion at that time point, then you can see it has high K-trans, high plasma volume, and it's hot on the FDG PET. So you have kind of two pieces of information confirming that, it is tumor, and the patient got Bev. And what Bev does is, Avastin, is it decreases vascularity. It may or may not have direct, it may not really improve survival. It may not have a great anti-tumor effect, but it does have direct effects on vasculature. And so enhancement usually goes way down right away. So this is 3 months later. You can see enhancement, actually the intensity of the brightness is decreased, but it doesn't have great anti-tumor effects in glioblastoma, at least. And so the extent or the size of the enhancing lesion actually continue to grow. It's a little bit more ill-defined, and then a few months later after that, so 9 months after really here, it's bilateral, and the patient did pretty poorly and died soon after that. So Bev can be effective to kind of control edema and then decrease enhancement, but this really simple way to think about Bev is that once you have increased enhancement on Bev, it's almost always tumor, just because that's what happens. This is a patient with breast cancer. You can see a MET, and you get SRS, and the MET goes away, and then they develop new METs. There's some other ones here as well, and they get whole brain this time to treat all the tiny METs that you see. They all kind of get better. Maybe one pops up, maybe kind of goes along. And so, we have, if anything, Memorial does a really good job of scanning a lot, right? So we have a lot of scans, and you can kind of see over this time frame that, you went from this 2 centimeter mass to nothing to tiny, and then continue to grow very slowly. By the time we did lit or laser interstitial thermal therapy, they did biopsy at that time. They only got, necrosis, no tumor. So, if you look at this as a whole and you had the luxury of kind of looking through multiple scans and said, this is probably necrosis because it got SRS and whole brain, and that's 2 doses of radiation to the same area. If you did perfusion at that time point, though, you could see how before treatment it was very bright. After treatment, it was kind of not very bright. And so, perfusion can be helpful, even in very early time points. And so the perfusion and having PET as well to confirm, again, slightly different pieces of information. Perfusion is correlated with vascularity of the tumor or not in necrosis. FDG is correlated with glucose uptake or metabolism. And they're different pieces of information, but they're both cold in this January scan. And so that's pretty good confidence that you're looking at necrosis, even though it continues to grow and grows enough that it warranted therapy. And this therapy is warranted really because for symptom control, right? So this was treated not because we were concerned that it was tumor, but because it was growing enough that they wanted to control the size. And you can argue that the edema did get better. The size was pretty slow to shrink, but it has continued to shrink slowly. And we also did delayed contrast, and delayed contrast is something we do here, and it's an extra scan. So we get an extra sequence. It's not an extra injection, it's an extra scan, an extra 5-minute scan an hour after injection. And it's basically a subtraction of the delayed 1-hour scan versus the immediate post-contrast scan. And the easy, simple way is like blue is bad. So blue is contrast clearance. And so tumors are able to clear contrast, even though they do it very inefficiently. And then the areas of necrosis and inflammation are encoded in red for contrast accumulation, because the contrast can get in there, but they can't. There's no functional blood vessels, so they kind of get trapped. It's trapped. So, having this kind of incomplete blue rim or kind of, irregular blue rim is also been described as a feature of necrosis, not for tumor. So out of all the kind of options that we have for advanced imaging, we do, literally thousands of perfusion scans a year, and diffusion standard on everything. We do spectroscopy. I didn't talk about it much, but spectroscopy requires a 2-centimeter mass. So it's a good option for patients who have larger tumors, or if they're on BEV and you don't expect perfusion to work because perfusion is vascularity based. We found spectroscopy and perfusion, the PET, to be helpful in patients who are on BEV. And then we have kind of a menu of imaging trials, again, depending on funding. So we have right now CEST and RSI and hyperpolarizer, and we kind of had these other agents at one time point or another, and we're in the middle of getting grants to try to do more of those things. And that's it. So